On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com.
Pain management. When does it get bad enough when you have to seek other medical help other than just over-the-counter medication? We've all heard about acupuncture, steroid shots, and also even surgery, but have you ever heard about radiation medicine for chronic pain? I haven't either, and I'm really looking forward to tonight's program. This evening's program is underwritten by Rio Grande Cancer Specialists, and we also want to say thank you to the El Paso County Medical Society for bringing the show to you. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thanks for joining us. We're going to be talking about pain management. All of us have felt pain in one way or another. And do we always take over-the-counter medications? We've talked about steroid shots, we've talked about acupuncture, and then sometimes surgery, but there is something new that I'm very excited to talk about. Dr. Travis Mendel and I have talked through the years about just hints of what this is going to be all about. But with me this evening is Dr. Travis Mendel, who is the medical director of Rio Grande Cancer Specialists. And also joining me is Brian Nabhan, who is the director of oncology at the Rio Grande Cancer Specialists as well. So, Dr. Mendel, we've done several shows together, and I feel like every time you're on, there's like, what? That's new, and you're that guy. So within tonight's discussion, what are we talking about with what you do all day, every day when it comes to pain management and radiation?
So I guess I can start by saying I'm a radiation oncologist. So we typically use radiation therapy as a therapeutic for malignancies, typically solid tumors. And so my day is I see patients who have, majority of my patients have cancer diagnoses, and we're working with the surgical surgeons, surgical oncologists, the medical oncologists, and we're as a team to kind of help these patients and hopefully cure these patients of their disease. There's been a pretty big push in the US more recently for more benign conditions, and actually radiation therapy has traditionally been used for actually many benign conditions. And so what we've been doing more treatments for is osteoarthritis, Dupuytren's contractures, plantar fasciitis, these kind of inflammatory conditions that many patients have and suffer from.
And so in that, I'm again excited to talk about this because these are common everyday issues that the majority of us have as we start aging. So thank you so much for being here. And Brian, I want to say thank you for reaching out. You reached out several months ago and said, hey, should we do a show about this? I'm like, heck yeah, let's do. So within your realm at Rio Grande Cancer Specialists, what is it that you do all day, every day?
So my role is the director of oncology, and I oversee the administrative and clinical leadership for the group. But I think the easiest way for me to say what I do is I try to keep him as busy as possible.
Oh, lucky you.
It keeps me in line.
Yeah, it keeps you in line, but he does like to take these vacations and go on these big hikes and everything, so give him some room here and there to do that, right? So I want to start off with, and it seems so simple and it seems so benign, but when we talk about radiation therapy, it's the radiation therapy that we all know about treating cancers. Describe what physiologically radiation does to the body, treating cancers, but then also pain management. How can you explain that to someone who's a layman and doesn't get it?
Perfect. Yeah, so radiation, I mean, we use radiation in medicine in many different ways. I mean, we have PET imaging, we have CT scans, we have X-ray scans. I mean, we have all these scans and we're using radiation to image patients. We use radiation as a therapeutic, and so the energy is much higher, but you can't see it, you can't feel it, you're not gonna be radioactive or anything like that. You really are, just receiving this therapy that's almost non-invasive. Mm-hmm. typically when we're using it to kill cancer, we're directing or focusing the radiation on the actual tumor. It damages the DNA within those cells. And tumors are really focused on replicating and growing. They're not focused on repairing their DNA. They kind of lose that ability as they become malignant. And so the radiation, what it does is it damages the DNA. The cells try to divide, but that's their roadmap. You need to have your DNAs there to kind of guide the cell to make a new one, essentially. And if it's damaged, the cell dies. That's called apoptosis. Okay. But with radiation in terms of like benign conditions, it's specifically these inflammatory conditions. Inflammatory cells are actually very sensitive to radiation. The mechanism for how this works is still kind of gray, but the way I think about it is, you have these inflammatory cells, they die almost immediately when they're exposed to radiation. So if you have inflammation in one of your joints or your hands or your knees or whatever, and we treat you with very low doses of radiation, that it removes that inflammatory response inside the joint. And that's why these patients have relief from their pain.
So it sounds so almost simple the way you're describing it. And Brian, I'd love for you to kind of hop in as the director of the facility. When you are describing the pain management with radiation to people who are coming in for the first time or people who are being referred to you all for the first time, how is it that you are describing it to patients that are coming in? Like the different options that they can have? Right.
Well, with these patients, this is a relatively new service line for the group. The patients that are coming in that are seeking this type of treatment, they've probably been progressing through the healthcare system where they started out taking over the counters, maybe even got to ortho and started getting injections or physical therapy. It's an easy conversation to have with them when we tell them that this is non-invasive. It's not going to be a large interruption to their schedule. It's also a short course of treatment. For most patients, they're only looking at getting 6 fractions of radiation.
So expand a little bit on that. Usually with radiation for cancer treatment, every day for, 6-8 weeks. And of course, it's different with everything else. So when you say it's short, because again, I'm trying to think about what the layman, what everybody at home is thinking about radiation and kind of changing their thought process of why and how this is different. So when you're talking about a short course, when you say 6 treatments, is that within a couple of days? Is that within a day, over a couple of weeks? And I know everybody's different, but just in general, how does that play out?
And typically, we're scheduling these patients twice a week for 3 weeks.
Okay.
It is and the treatment itself is also very brief. Probably about 10 minutes in the room.
Okay. And so, yes, Dr.
So I was going to add, so we call this low dose radiation. So for example, if I'm treating a prostate cancer, I'm going to give it 70 units or 80 units of radiation. This is a total of 3 over 6 sessions. And so the dose is incredibly low. And it's actually comical. And I remember before I started doing this, one of my friends out in East Texas set up a clinic similar to what we're establishing here. And I thought it was a racket. I was just like, this is, no.
Can't be this easy.
And so I went and talked to him. We're very close. We were in residency together. And we were having a beer and he was just like, hey man, let me show you this. And he had this patient who was a painter. And the guy could barely open his hand and close it, and he's in his 70s. He's been a painter his whole life. It's what he loves to do. And he treated him. And then the guy, after treatment, is just like this.
Wow.
Ready to go paint.
So was he osteoarthritis? Was that his issue? His
hands, yeah. So he just had his hands. So he treated both of his hands. And it doesn't last forever, but the guy's going to get probably a year or two of just more mobility, less pain, and he can do the things he loves. Versus just, taking Tylenol and barely being able to hold the paintbrush.
Right.
And so once he told me that, then I was like,
I need to learn about this.
It really
on that
works.
note, I would like for you to kind of talk about You learning this specifically. I mean, you're doing radiation oncology, yes, but you see this and you're thinking, wow. So talk about your training. How'd you, obviously there's an interest there, you want to dive in. What's your training around this?
So it's really the techniques that we use to deliver the therapy are very basic. It's like the basic setups that you learn in residency and things like that, just with extremely low doses. And once I started kind of thinking maybe this is something we should be offering the community, I got radiation oncology is a very small community nationally. There's not that many of us, and so everyone knows each other. And so I got in touch with Bobby Conroe, who's like the national leader in this. And he got on a phone call with me, went over, he had a big Astro presentation maybe a year ago. This is a national radiation oncology group. Within a week, he was on the phone with me on a virtual call for 2 hours going over everything. And then he has a course that we all took, actually. It was probably 8 of us that took it, and they go over all the different conditions you can treat, how to do it, what dose to give, the biology behind it, things like that, or the expected biology behind it, things like that. And so you get your little training certificate and things like that. But it's pretty basic. It's not that difficult. It's very safe. And I have a couple of slides on this, but people are always worried about secondary malignancies and things like that.
Right.
And so we are very conscious of that risk. And so usually we're offering this to patients that are over 40. We definitely don't want to be doing this to like an 18-year-old or something like that, because they're at higher risk of developing they're going to live longer, and so their risk is higher as they live longer.
Right.
But the secondary malignancy risk in terms of like treating your hand or your knee or your elbow or something like that is almost the same as getting a CT scan of your abdomen and pelvis.
Yeah, I read that and I thought to myself, okay, how many times do you get dental x-rays?
Exactly,
right.
And so the risk is extremely low to these different areas, and the dose is very low. And so to me, if there's going to be a benefit for the patients and there's the risk of harming anyone is extremely low,
right,
then it's done deal in my eyes.
Right.
So that's why.
So I want to get back to, I'm going to ask Brian a question, but I do want to get back to osteoarthritis, because I feel like of all the things that we have here, that's one of the biggest that all of us deal with. I'm 58, as I said earlier, so I'm starting to feel little things here and there. It's like, what is it?
Me too.
But yeah, right. Well, you too, and you guys are so young. And Brian, when Dr. Mendel was talking about the biology of all this, with the biology of the radiation, if you could break that down. I know you were talking about, again, it's inflammation. You're trying to break that down. So with this radiation, and you're learning about the biology of this radiation and how it affects physiologically every person, is there something that stuck out to you when you were going through the trainings of, I didn't know that this could be this simple?
That's a great question, because I myself am also a radiation therapist. So I've been treating patients on our treatment equipment for almost 15 years now. And when we started talking about the use of radiation for benign conditions, it was scary for me, because I know the biology of how radiation affects our cells. But once we started doing the training, and we had an opportunity to get a better understanding of what dose ranges we were looking at, the field setups that we were going to be using, it really alleviated a lot of that initial gut reaction to want to protect the patients. And it became clear pretty quickly that this was going to be something that was really going to benefit our community.
And how long has this therapy, I know you said your radiation therapy, how long has this type of pain management radiation therapy been around? I know when you said you came across it.
Decades.
It's been around for decades.
Yes.
Okay.
So it used to be more common, but because of this push to kind of get rid of radiation because it's dangerous, it kind of went by the wayside in the U.S. However, in Europe, specifically in Germany, it is an extremely common treatment, and actually almost half the patients receiving radiation therapy in Germany are receiving it for a benign condition. And it's hilarious. There's a slide in there of Usain Bolt. He's that guy who's sitting on like next to the linear accelerator, but he's the world's fastest man. He
And
won.
for editing later, it's slide number 7. But yeah, okay.
But he in the Rio Games won 3 or 4 gold medals. And before his race, he developed plantar fasciitis. And so his trainer was German, knew about this therapy, and put him in a plane, took him off, got him his treatments, came back. The guy won, many gold medals, and he was suffering from plantar fasciitis, which I don't know if you've ever had before, but it is very painful.
I haven't. I know I talked about osteoarthritis, but let's go to plantar fasciitis really quick, because I know a lot of people who have, knock on wood, I haven't. That'd be great to physiologically explain what is happening in your foot with plantar fasciitis.
So you're developing almost like a chronic inflammation in the bottom part. It's called the plantar aspect of your foot, and it's very common in runners. Like I run quite a bit, and it's almost everyone gets it, but it goes away. I get it pretty frequently, and I'll freeze a water bottle, and I'll put that on my foot and I'll just rub it out. And it lasts for maybe like a week or so, and I'm sore, but I can still kind of run, it's okay. But some people get it and it lasts for like 3 to 6 months. And when it's bad, it really hurts. You really can't put pain, like the weight on your foot because of the pain. And so I can't even fathom having that for 6 months. I mean, there's no way you could train. And mostly people that are getting this, they're athletes, right? They're like, that's what they like to do is exercise and run. And so you take that away from someone for 3 to 6 months. It's miserable.
Messes with them.
Yeah, because you're getting out of shape. You can't do what you like to do. You're emotionally, you're all a wreck because you're just like stressed out all the time because you haven't been exercising. That's what happens to me. No. If I don't exercise, I'm just like, can't control myself.
You need that release.
But basically this is an option for patients who have this kind of chronic plantar fasciitis and need it fixed, like Usain Bolt.
Right.
But they've studied this. There's a study in here where they compared the radiation therapy to actually steroid injections to these patients with plantar fasciitis. The radiation therapy was twice as effective. Just like night and day better. And so in Europe, this is like a common therapy. Here, people just don't. It doesn't even come to the providers' minds. And the issue that we have is it's really just education. And so what we've been doing is going around and talking to some of the primary care doctors and things, the sports medicine physicians, orthopedics, just to explain to them, hey, this is an option for your patients because I'm not going to see these patients.
Right.
I'm seeing oncology.
You need to be
patients.
referred to.
Yeah.
Right.
I have some patients that are like, my hands hurt, I heard about this or whatever, and we help them, but it's really more of a community education kind of situation where a lot of our referring providers are now like family practice physicians that are sending their patients with arthritis or plantar fasciitis or Dupuytren's and all these benign conditions that they had no clue about this.
Right.
But the patients like it, they get relief. Some of the patients get relief even while they're receiving the treatments. It's been they've had 2 or 3 treatments and they're like, my shoulder feels better.
It's all there.
It's hilarious.
It's all. So I would like, Brian, if you could, so explain for people who are completely unfamiliar with any kind of radiation treatment, therapy, et cetera. So let's say plantar fasciitis, and they're now in the room with the radiation machine. Describe what it is that happens. If it's on your foot, do you just have the radiation machine over your foot? Just describe what's going on in the room while you're getting the treatment.
And you might want to bring up the CT simulation.
Sure.
Oh.
Yeah.
Okay.
It actually starts well before going into the room for the treatment.
Okay.
One of the first steps in the process is to come in and have a CT scan performed for whatever the treatment is. And you'll come into the clinic, you'll be escorted into the CT room, placed onto the table, into a position that's going to be conducive for your particular treatment. Mm-hmm. Breasts, prostate, or plantar fasciitis. Mm-hmm. And in that CT scan, we refer to it as a CT simulation. We're placing you into that actual treatment position that you would be in for your treatments. You're scanned at that time. That scan is used by our physics department and our dosimetrists to plan out the geometric, the geometry for your treatment.
Okay.
And how the machine is going to deliver those little packets of radiation to your treatment area.
Okay. And you don't feel anything.
And you
I think
don't
that's
feel
important
anything.
for the audience to know that you don't feel it. And
Yeah.
that's, again, for people who are not familiar with it, how does it feel? You know, throw that out there.
It feels boring.
Okay.
That's what I always tell
that's
patients.
a good thing. That's a good thing.
It feels boring because so many people will work themselves up thinking that they're going to feel something, or they'll hear from family members, oh, you'll feel it burning you, or you'll feel it tingling. And we leave the room. We don't want to be in there when the radiation is being delivered. We want that all for our patients. So we leave the room, we deliver the treatment, and we come back in, and invariably, often, patients will say, when are you going to start?
Oh, geez.
And we say, we're done already.
Wow.
You know?
Beautiful.
Yeah.
Okay. So let's go to osteoarthritis now. And let's go to hands, because I feel like that's where a lot of people feel it. So what I'd like to do first is kind of describe the symptoms that people come to you with. Like, this is what I'm feeling, thumbs, fingers, in general. You were just talking about the pain. I love case studies. You know how I love case studies. So there's this painter that comes in. He is maybe through the years unable to start moving a digit, 2 or 3 digits. Talk about how that starts. Then we get to a point where let's see if we can do some pain medication with radiation.
I mean, everyone's a little different. I think some people sometimes have just like focal areas of arthritis, like in one joint or two. Some people have it all over their entire hand. You know, the patients will come in for a consultation, and we'll kind of take a history and see what's been going on. I mean, and if it's a patient that's just like, oh, my hand is a little bit sore, and maybe I take a Tylenol once a week and I'm fine. That is not a patient that we're going to be treating. We're looking for patients that are like, I've had multiple surgeries on my hand because I have this arthritis. I'm taking narcotics or ibuprofen 800s every day, which is not good for you. Right. And so those are the patients we're kind of targeting. These are the patients that are kind of like heading towards some type of much more invasive intervention. Like a great example would be like a knee replacement or a hip replacement. These kind of like pretty invasive procedures, which are 100% necessary in a lot of individuals, but a lot of patients, they'd rather just kind of like postpone it. Or you have your guy who's 80 years old and he doesn't want to have a huge surgery. Right. So these kind of things are, we're offering this to the patients so that they can kind of kick the can down the road and maybe avoid it if possible. But, to go back to your question, we evaluate the patients. Typically, we want to make sure that they've had some type of intervention. Whether it's just been like they've been on Tylenol, that's fine. But we don't want patients taking, pain medication every single day because of their arthritis.
And I know a lot of people who do.
Oh, yeah.
And like you said, it's not good for the system.
Yeah. And I'm the first one, if I have like a sore muscle or like my knee hurts from running or something, I'm like Tylenol, ibuprofen, I'm like, let's go. But I would do it for like a week tops. If it's more than that, it's not, ibuprofen particularly is not good for your stomach. It's not good for your kidneys. And especially as you get older, these effects are much more substantial than, a guy in his 30s. So
we start the treatment now on this person that has a hand. You were talking about each joint is different. Is radiation then given to, like, is it pinpointed where a little bit to this joint, a little bit to this joint? You talked about low dose, so I don't know if that's something that goes everywhere.
Yeah, so typically what we do, the main thing I'm worried about is people losing their fingernails. And so what we do when we set them up for our CT simulation, we put some wires on their nails so we know exactly where their nails are and we can avoid them. So to help prevent that from happening.
Okay.
I've never seen it happen, but theoretically it could. Some people will treat the individual joints. In my eyes, the dose is so incredibly low that I just treat the whole hand. Like if they have, pain here, some pain here, I'll just treat the entire
That way everything gets
hand.
Yeah. Everything gets the love.
Yeah.
Okay.
Yeah, and the doses, it's just incredibly low. There's like absolutely no way of like harming someone or like, preventing them from having some type of like surgery in the future or anything like that. Mm-hmm. And so I just treat the whole hand, and you can do this several times. So say the patient responds or they have a partial response or something like that at 3 months after the treatment, we'll treat them again and hopefully give them more pain relief. Or say this patient, their arthritis has been good for 2 years after their treatment. Now they're back saying it's coming back. Then you treat them again, and the dose that you're giving is honestly, it's in one treatment that I give for like regular cancers, like one of the fractions over the course of like 1 to 2 months. That's what you're getting in 6 treatments.
Oh, wow.
It's the dose is just like
so it is
low. Yeah.
And that's something I really
comical.
want to get across today, because I think just the word radiation, for the lack of a better word, kind of scares people. Yeah. So if we can talk about, and you said again, it's like doing one scan, or again, I look at dental x-rays. I mean, if you go to the dentist regularly, you get one every year.
Yeah. And
that is radiation.
No, gonna give me cancer? Like no one ever like asked or thinks
My brother's
about it.
a pilot. And I'm thinking, okay, he talks about radiation that you get when you're in an airplane. People talk about that kind of radiation. So just in the idea of putting it into perspective for people of, okay, when you take an airplane ride, you get so much radiation anyway. People don't think about that. Yeah. So coming into this type of a specific area of not feeling the fear, so to speak. So I know I have a lot of your slides here, and I don't know if you're able to pull them up on there, but I would love for you to kind of go through the slides that you think are the most important slides to touch base on. I know we talked a little bit about plantar fasciitis, osteoarthritis, humeral epicondylopathy.
So that's yeah.
That's page 14.
That's golfer tennis elbow.
Oh, there you. So, why not just say tennis elbow? Okay, tennis or golf elbow. Oh my gosh, so that's a big one too.
Yeah, so we have a lot of golfers in my practice, and they come and want us to treat their elbow or whatever, and so they can keep playing.
So that's another thing too. When someone gets tennis elbow, and I know we've been talking about inflammation, right? What exactly is it? Overuse, obviously, hit. Why is it getting inflamed?
It's just the like having a chronically inflamed joint or tendon that's there, and usually like with golf or tennis elbow, if you just kind of rest and ice it, it goes away. Right, I play golf and I've played a little tennis, but I've gotten these like a golf elbow before, and it goes away after a week. But these are the patients we're treating are the patients that it's been there for months and it's not going away. And so the patients that are like, oh, just out shagging balls right now and my elbow hurts, that's not the patient you want to treat. You want to treat these guys that was like, I haven't been able to play golf for 6 months. And it's like, that's the only thing I like to do in my life right now, And so those are the patients you want to treat. And the guys that have been, been in pain for maybe a week or two, just have them take some Tylenol, ice it, rest, and then usually your body will heal on its own. But
so in the opening of this show, I was thinking, when do you know it's time to have true intervention?
Yeah.
So a week or two, no. But if someone has been feeling it for months.
Yeah, months is kind of the deal. And here, they kind of talk about like, who are we targeting? Who's a candidate? And it's like arthritis in the knee. There's a good slide here where you have physical therapy, weight loss, topical therapies, maybe some NSAIDs. But once you're starting, NSAIDs are like ibuprofen, naproxen, these kind of medications that you can get over the counter. Once you start getting into narcotic pain medications, steroid injections, hyaluronic acid injections, like surgical interventions, whether it's cleaning out your joint or going in and doing a total knee replacement, those we're trying to capture the patients from taking a little bit of medications versus full-on surgery. We want to capture them right here in the middle to help prevent them from having to go through these more invasive procedures. And just like everything, it doesn't work forever. And I don't know if you've ever had steroid injections before, but they really only last for 4 to 6 months. And then you have to get another injection. And then they become, as you get more injections, they become less and less responsive, and your arthritis comes back. Now it's, you've had 3 injections, now it's coming back at 3 months, these kind of things. And I'm assuming that's probably the same with the radiation, is it's just like your joints getting a little bit more beat up over the years, and now you're having more arthritis.
Right.
But it's just that chronic inflammation, and the picture here kind of shows you. You have your normal joint, it looks smooth, healthy, but you start getting chronic inflammation, and the inflammatory effects just kind of damage the interior of the joint to where it becomes so damaged that it cannot, function or repair itself. And those are the patients that go on to get total knee replacements.
Okay.
Yeah.
Gotcha. Yes, Brian?
I was just going to say, I think one of the best ways to look at it is this is not a first-line therapy for the treatment of these conditions. This is when you have, as we've said a couple of times, chronic and acute pain that is not going to be controlled with over-the-counter medication or even physical therapy anymore, where you've got to start looking at that next step.
Yeah, I'm trying to see it almost like the middle stage, right? It's not in the very beginning. You're hurting for several months, and before even consider surgery, maybe give this a shot. And you were saying earlier, and I was reading my paper as you were talking, but you were saying that you can get a full treatment, the 3 weeks or whatever you need to do. It lasts a year, 2 years, maybe another treatment. So that's also something that's an option. Like you were talking about this painter. You said this is probably going to last him about 2 years, and he's almost 80. Would the option be then for him to get radiation again?
Sure.
And would there be a certain stopping point, or?
So everyone has their limit.
Right. Okay.
And so the tissue, every tissue has this kind of like lifelong exposure maximum to radiation. I think for me, if the patients come like 5 or 6 times, it's probably where I'm going to say, hey, this isn't really working that well for you. We don't want to keep doing it. But if it's the second or third time, and it's very common to come back at 3 months and you've had a partial response. So the statistics on it are at least 70 to 80% of patients will have some pain response. So the majority of patients will respond, but what we're looking for is a complete response in the pain.
Right.
And so they typically come back at 3 months. Half of the patients that have had a response will most likely require another treatment because they've only just had a partial response. They feel better and they're like, man, it's so much better now, but I still have it. Right. We hit them again, so we can hopefully get them to a complete response in the pain so they don't have to take anything for it.
So I'm just trying to understand and re-say this out loud. So what we're looking at doing is decreasing inflammation. And I am going to ask a selfish question. I'm 58, so I have adhesive capsulitis of my shoulder. And it's supposed to take about 2 years to go away unless you do something with it. Is this something that could be an option as well? And maybe we can, frozen shoulder is what a lot of people call it. Or somebody called it the 40-year-old shoulder and then frozen shoulder. So when I thought, what did I do to my shoulder? And it was just hurting for months. And I finally went to an orthoped, and he said, yeah, you got a typical frozen shoulder, just stretch it, do exercises, but it hurts. Yeah. Is this something that could be an option for that? Because I know that we're looking at joints.
So it probably has not been studied, that specific condition.
Okay.
And I think it's probably less likely to respond than just like arthritis in your shoulder.
Because it's not a joint.
Yeah.
Right? Is that?
Well, it's a joint, but I think, when you're talking about frozen shoulder, it's more of you have like the scar tissues in there. It's already formed, kind of like that picture I showed you.
Right.
It's already in there and it's just like sticking to itself and then it can't move. Whether or not the radiation would help prevent that, that from freezing up again, I'm not sure. I've treated quite a few shoulders at this point, and it's been kind of fascinating to see the responses, because some of the guys, one of the guys I have that has his like frozen shoulder, he can't really move it. It didn't really do much for him, to be honest.
Okay.
And I have another guy that just had arthritis to the point where he couldn't even lay on his shoulder at night. And by his last treatment, he's like moving his arm around.
That's me. I can't lay on my shoulder at all.
Yeah. So it's the same thing with this guy. So he, after his last treatment, he's laying on it, sleeping on his shoulder. He's fine. He's happy. He's like, look at my arm. I can move it. He's all happy.
So this is a perfect transition as to what shoulder issues can be treated with this. So we were talking about rotator cuff earlier, right? Rotator cuff syndrome. And I know we have slide 15 in here that talks about that. So with that and treating it, maybe let's talk about the rotator cuff. Again, physiologically, for people that don't know, what is going on in the rotator cuff when that syndrome is affecting a person?
I mean, I think, any condition that's like inflammatory in nature, I think would be a candidate for at least trying it. Your shoulder is your most like mobile joint, right? And so that's why I've had so many shoulder injuries just because like playing football,
right?
And, golfing and all these things. So it's like this joint that is susceptible to kind of damage because it's just so mobile. You can pop your socket out, right? Mm-hmm. So I think anything that's like kind of associated with inflammation, I think has a chance of working. And we've had patients where it's not kind of like the standard thing you would think of like arthritis of the shoulder, but they're like, my shoulder hurts all the time. And we treat them, and some of them have a response and some don't. And to me, especially a guy that's like 70 years old, there's really no harm in giving it a shot.
Right.
Like they don't really have any other option. They're kind of just miserable. And they're like, we'll give it a shot. Right. It's not going to hurt you. It's, it might work, it might not. And most of them are like, go for it.
Exactly. And Brian, I'll ask you, how is the evaluation done? So somebody comes in and says, my shoulder hurts all the time. What is it that you all do to, for the lack of a better word, diagnose it? Whether it's isolated capsulitis, is it rotator cuff issues, is it just joints messing up? How is it that you go in? What imaging do you use to diagnose what's going on to see what the treatment will be going forward?
We need Beth here for this. Yeah. So we have.
Beth, where's Beth?
Yeah. So my PA, she's is like probably the most meticulous person I've ever met. So she has, with all these diagnoses, all the criteria that meet that diagnosis on her note. And so majority of the time, she actually meets the patient in consultation, and will go over kind of their diagnosis, their history, and then she has in her note all the criteria to make that diagnosis. And most of these are clinical. Like you can, like with plantar fasciitis, you can get an MRI or a CT scan and see the little bone spur and stuff like that. But most of this is clinical, where you're just kind of ticking off the box of, how long has it been? What have you done for it? Is it swollen? There's all these different criteria that will allow you to meet that diagnosis. And a lot of the patients come in with that diagnosis already because they've been seeing their PCP or their orthopedic, physician, and they've already came with that diagnosis. And so we already know they have that. So we just, manage it that way.
Okay.
But it's definitely, most of this is clinical. It's sitting down with the patient for 30 minutes and trying to decipher what's been going on and why they have this pain, especially if it's a new diagnosis.
Right. And with diagnosis, and this is always the ugly question to ask doctors, but with a diagnosis is insurance and medically necessary, et cetera, et cetera. And it's an ugly question, but people always want to know. So if it's pain management, you were talking about benign, and the word benign to me with insurance, it's benign. How in general, and I know you have someone at your office that deals with this, and I know it's an ugly question and would have to spend a long time on it, but in general, how does that Brian,
for this.
Brian, you're the guy, because you're the director,
yes.
After all.
Surprisingly, we have had little to no kickback from the insurance companies.
Very nice.
It is a service that's covered by almost all insurances. The patients generally, if they have a deductible or a copayment that goes with their insurance,
it kind of goes along with that.
Yeah,
okay.
This falls into there.
I like that.
But yeah, it is a service that is covered by the majority of insurances.
And that was my first question when this was brought up. I'm like, are the patients having to pay for this, or is this covered by the insurance?
Yeah.
And even the insurers that are notorious for just being a huge pain in the butt,
right?
They're
pay covering
for it.
it.
Yeah, it's in their guidelines.
Yeah. Okay.
Yeah. So we've had a couple of issues with the image guidance. And so we typically take images before we deliver therapy to assure that we're treating the right area. We use the CT simulation and we match up the current position of the patient to the CT scan so we know we're delivering it directly how we had planned it. We've had some issues with that, which is not a big deal. We're just like, whatever. But that's really been the only thing.
Right, which to me doesn't seem like a lot at all. I'm dealing with some stuff with my son and, surgeries, but well, it's not necessary. And so it's just hard for people who, again, diagnosis, where do you go from there? And I want to say this out loud again too, in case somebody wants to come, that this is something for the most part is covered with insurances.
It is.
Yes. You were talking about, I'm not even going to try to pronounce this.
Dupuytren's contractures. So that's when patients will develop this kind of scar tissue, these little nodules that, I don't know if you've ever seen people with like a trigger finger.
Yes.
It just goes like that and stays like that.
Very familiar with that, yes.
Yeah. So what we do with radiation is, as that's happening, this is something that happens over the course of months to years, right? Where you just develop these little nodules and your fingers just start kind of going like that.
Yes.
And to fix this, like a fully contracted finger, they have to slice open your hand and then relieve all those cords and tendons that are kind of bunched up, basically, contracted in your hand. And there's a great picture of what your hand looks like
I want to
after
talk about
these
carpal
surgeries.
tunnel in a minute too, because I feel like that.
And that doesn't look very pleasant to me at all.
Right.
And so what we do is, as this is forming, and we're in the process of going to talk to some of the hand surgeons, is when this is happening and you can see you can feel the nodules and things like that. That's the perfect time to do the radiation, because it stops the formation of those nodules and the contraction in the hand. And it's actually like quite successful. I mean, it's probably like 70-80% of the patients will have like a complete remission.
Wow.
Remission, or just that it kind of stops. It usually doesn't, if the fingers like this and we treated them, it won't go back to normal, but it'll prevent it from getting a full contracture, essentially.
And the
so
pain
it
that is
freezes
associated
it.
with that too is phenomenal. I mean, it just
you just can't open your hand. And of course, I mean, we use our hands for everything.
Yeah.
And I don't know if you've ever hurt your finger and you didn't realize, man, I use my little finger so much. It's all day long. You're
especially for the tea.
Ow, So I can't imagine if your hands just close and you just can't what do you do, right? Especially when you're older.
Mm-hmm.
So I think this is a cool therapy. Definitely something that we need to spend more time, discussing with the hand surgeons and things like that.
And so when people see this on the screen, you were talking about covering the finger, the tips of the fingers here. And so with radiation, again, you are radiating the entire hand with low dose so that it kind of spreads everywhere and try to help. Is that correct?
Yeah, so the technique for this one specifically, we actually use higher doses for the Dupuytren's contractures. And we use typically a technique called electron therapy. So we fire electrons at the hand, and they only penetrate superficially. They don't go all the way through your hand like an X-ray would. And so we usually put a material, it's like fake skin on your hand, and then we treat kind of the maybe half the depth of your hand, something like that, in order to kind of disrupt these inflammatory and scar tissue formation in there. There's another process called Peyronie's disease, where men, when they have an erection, they have a very similar type of scar tissue that forms on the shaft of the penis, and it causes it to curve when they have an erection. Right. And we do radiation for that. Okay. And it's fascinating because we were able to prevent this from actually the actual plaque from forming in these patients.
So again, physiologically, just so I understand it, so you're looking at, you have plaque in there, you have the curvature, whatever. Is the radiation breaking up that tissue?
It's preventing further formation of the plaque. Okay. And so the plaque forms, and just like a scar, it'll contract and it gets firm and it'll pull the skin in, and you always see everything's tight. It's the same thing internally with these conditions. And we're preventing the scar from forming. And the issue is that the treatments that we give for patients now, we wait for the scar, there's an injection that we can give to help, the surgery, things like that. They wait until the scar is completely formed before they do any type of intervention like this. And so we're at the part where we're like, well, why don't we try this first? And then if they need the injection or whatever, the surgery afterwards, do the surgery or give the injection. It's not going to prevent them from having that. Right. But at least we're able to hopefully prevent it from happening in a majority of patients.
Right.
It's just no one knows about it. Yeah. Right. So you're just we have to go out and educate and tell,
that's Brian's
these
job.
Providers, right?
He's out here telling people about it, and I love everything about that. Parkinson's tremor. Again, I'm just trying to think of things that people are familiar with, because we know a lot of people that they have a tremor, it goes away, it comes back. How can benign radiation therapy help with that?
So some of these are more novel and they're being explored. Parkinson's is one of those that's being explored. Alzheimer's is being explored. And these are things that we think are going to become more prominent in the future because people are kind of studying it. The Alzheimer's specifically, that study was on like 20 patients, but 60% of them had a reduction in their Alzheimer's and like diminished formation of their symptoms. And so they think that the interaction with the radiation in the brain is helping preventing that disease process.
Wow.
But all these things, they're kind of associated with like they're very different, right?
Yes,
so like if you have
exactly.
trigeminal neuralgia, that you're actually damaging the nerve root that's causing all the pain for these patients, and you're giving it a massive dose of radiation, but it's pinpoint right on the nerve,
Right.
And it works very well. It doesn't work forever, but it works for several years because you're actually damaging the nerve. In these cases, in the Alzheimer's, you're giving a lower dose to help disrupt the actual process for the disease, not damage the brain tissue. And all of these are they're all different. Like gynecomastia formation, that's like developing breasts in men, which can be quite painful. And so we have guys that are on androgen deprivation therapy for prostate cancer, and they start developing breast buds, and it's extremely painful. They can't have shirts on, and they're like, it's terrible. And we just treat that with actually 2 high doses of radiation. They have like a little sunburn in a circle, so don't go swimming after that. But it just freezes the formation of the breast tissue, and so they have a reduction in pain. They don't develop more breast tissue, which of course the guys are all stressed about when we discuss these things. So
And
all
that
these things are very
lasts, so
different.
that would be going on during treatment for prostate cancer. So after they're done treating prostate cancer, then that's not an issue anymore. So it's like a one-time treatment for something like that? Or
Yeah. Typically what ends up happening is the patients, like if you have high-risk cancer, you're on the hormone suppression for sometimes years.
Okay.
And nowadays it's not as common as it was before, but now with these novel hormonal agents that we have, we're able to that have less side effects, but they have more risk of developing gynecomastia. Okay. And the rates are like 70 to 80% of the patients that are receiving these things. Okay. So we do this very frequently where they come in, they're like, what is going on? And we just fix it.
Right, you just fix it.
Yeah.
I've just been given the 10-minute mark, and so what I usually do at this point, and Brian, I need to get you to do some more talking. That's my bad.
Sorry.
No.
Yeah, stop.
I like listening to him.
What are you excited about? When I say that, it's I try to use the end of the show usually of what is coming up. Like this to me, you said it's been going on for decades. Kind of went away for a while because of the scary word of radiation coming back into play. What do you see 5 to 10 years from now in this space? I see it, educating people coming to try it out. Anytime you try something out, there's more research on that, which I think is always a good thing. It's not clinical studies. This is real ongoing treatment that you all are doing. But in general, in your role, what do you see in this space 5 to 10 years from now?
I see this continuing to grow. I mean, you've got a great list of conditions there. That some are currently being treated, some are still in that exploratory phase. I see that list continuing to get larger and larger as more research is done on different conditions that can be treated as it becomes more mainstream. As Dr. Mendel mentioned, this has been very common in a lot of European countries, Germany for sure. For a very long time. As it starts to become, or as it starts to get adapted into the American landscape of treatment, it'll be very interesting to see the research that's done. It's exciting because this is something that, our community here in El Paso, we're usually not on the cutting edge. We wait.
He is.
A good
First time I
5 or
interviewed
8
him, I'm
years.
like, who is this guy? Yeah.
But we wait a good 5 or 8 years typically to start doing things in El Paso that are common in other areas. This is one of those cases where we're ahead of the curve here.
And I want to reiterate that you said that insurances, for the most part, are picking it up. And the way I look at too is research is once an insurance company covers something, then there's more ability for things to move forward. So I want to re-say that this is something that can be open and going forward. And if there's something more you think about, let me know. You always have like a laundry list of things that are coming up.
Oh yeah.
In this space, what do you see in the next 5, 10 years, even 20 years?
Well, I really think that people are really exploring more of these benign conditions and just, kind of experimenting with it. But a lot of times, the one thing that comes to mind right now is refractory ventricular tachycardia. So these are patients that
say that slowly. So we're looking at heart tachycardia?
Heart tachycardia, like your heart rate going very fast, and you're not able to stop it. And these patients, it's just basically a death sentence. And they have, there's a study that was published probably 5 or 10 years ago now, where they did high-dose focused radiation treatments to the heart, and these patients responded, and they had a massive reduction in these episodes that they have of tachycardia. And these patients are like in the ICU, and they're on all kinds of medications. And what we've been doing before is essentially your heart's like a circuit. So you have like electrical pulses that go through, and that's how your heart pumps. And you can develop a little scar tissue or an area of ischemia, something like that, to where the circuit just goes in a circle and keeps sending off the signal for your heart to beat, essentially. And so it goes around, and your heart just starts beating very fast, but it doesn't effectively pump blood, because it's beating way too fast, right? And so what they'll do is they'll go in there and they'll try to disrupt that area of the circuit. And they'll go in there and burn it or whatever. And we've discovered that you can actually use radiation to go in there and target that area and then reduce the circuit by damaging the cardiac tissue there. And so there's a lot of
When you're saying all this, I'm thinking almost like an ablation when we go in there. Okay, all right.
And when SBRT, it stands for stereotactic body radiotherapy.
Okay.
One of my mentors, who's very big in the field, he used to call it SABRE. And he'd always have his PowerPoint's presentation, and he's a farmer. And so he'd have cows and stuff like that. He lives in Fort Worth. But he'd always have himself on there holding a lightsaber. And it was standing for ablation therapy. The A is for ablation. And so these high doses of radiation, instead of thinking, we're damaging the DNA in the cells, the dose is so high we're essentially ablating the cancer. And so we do these techniques very frequently for metastatic disease, things like that, brain tumors. But these benign conditions that no one would have thought in a million years that this would be something that would be beneficial for these patients. But we're starting to see, well, maybe it does help. And one of the other ones that I was listening to a talk on were patients with sciatica, where they're going in and they're just focally treating the nerve root that's causing the pain.
Wow.
And the patients are having like significant improvements in their sciatica.
Because that is very, very specific. Okay.
Yeah, so you're just damaging the nerve root with radiation, nothing else, just the nerve root, and you're relieving the pain, just like you would with trigeminal neuralgia or any kind of other, like nerve-related pain. And so people have a lot of very strange nerve conditions that can be like completely debilitating. Like trigeminal neuralgia can be terrible.
Tell people what that is.
So it's basically when you have severe, like this constant horrible pain from your trigeminal nerve, which innervates your entire, half your face. And so they'll just have this excruciating pain that's just completely debilitating. They can't do anything. And they'll take all kinds of these like neuroleptics and different medications to try to help, and it typically doesn't. And we very, very commonly do radiation to this, typically with a gamma knife or some type of boutique machine, and it works very well. And it's a very well known in the neurosurgical realm treatment for this disorder. But they're exploring these other nerve disorders, like you can have like a glossopharyngeal nerve pain, You can have, sciatica, these are all nerve related pains. And so they're kind of looking in to see how, if we can treat that nerve, it's the same thing as doing the trigeminal neuralgia, it's just in a different site. And then these patients, potentially would have tremendous pain relief without having to do injections and surgery and decompression surgeries and all these things that we do.
And so you were talking about, and I'm going back to programs like trauma programs where somebody's like putting together somebody's hand again and then reconnecting nerves, that nerves have a way of, do they regenerate? And so when you're talking about that, addressing a nerve situation, and then the nerve tries to heal itself after you're trying, so that's when maybe the next treatment might come. I'm just trying to, again, physiologically figure out how that works.
So for trigeminal neuralgia, I spent a lot of time on the Gamma knife in Dallas, but basically you'll treat it, and the patients will sometimes have like paresthesias, like they'll get numb and things like that because you just killed the nerve.
Right.
But it comes back, and the nerve grows, and then it can the trigeminal neuralgia can come back. But at least they had relief for a year or two, and patients like these patients are miserable. Like they are begging for anything because they just can't function. It's just terrible pain. And it's the same thing with back pain. I mean, you're like, my back hurts and I complain about it, but I can't even imagine when I'm going to be 80.
I'm in my head, as you guys are talking, I'm like, I got this, I got this, I got this. Right? Oh yeah, no kidding.
And then you see all these people kind of limping around and stuff, and I'm like, well, that's probably
there's hope for us.
Me. Yeah, right.
Yeah.
Just radiate half my body and I'll be okay.
Right. Well, we were talking about like osteoarthritis, which may not always be osteoarthritis, right? But who does not have knee pain, shoulder pain, even ankle pain, just as we get older, whether it's arthritis or not, it's wear and tear. It is, you were talking about being an athlete. We've done a lot of things that kind of beat ourselves up. And I'm saying that too, and Brian, I will give this to you, when people are listening to this program and they're thinking, okay, can I just call you guys outright? Do you need to be referred by a physician to come see you guys? How does that work with people who are around and listening to this?
Our end goal is to help these people, right? We would love to have a primary doctor who's involved with their current care for the issue, refer that patient over. But anyone is welcome to self-refer.
Okay.
They can get onto our website, they can reach out to us, rgcshope.com.
There you go. I was going to say, this is the Rio Grande Cancer Specialists. We are out of time, but man, I could do this topic 12 different times and still learn stuff. Again, we've had Dr. Travis Mendel with us. We've had Brian Nabhan with us. And this has been No Scalpels Needed. I kind of love the title, Radiation Medicine for Chronic Pain. If you were just you just tuned in, want to watch us again, and or if you want to show it to somebody else, explain what everything's going on, you can do that in 3 different places at pbselpaso.org. Just go to that website, find the El Paso Physician. This episode will be there. Also, the El Paso County Medical Society.com. That's EPCMS.com. And then YouTube. You can find anything on YouTube these days. Just type in the El Paso Physician, and then you can go specifically to No Scalpels Needed, or if you want to look up radiation medicine for chronic pain, it'll be there as well. So please join us for any of that, and know that all the episodes that we've got for years are located on there. Thank you so much for joining us. We are taping in the beautiful Turner home of the El Paso County Medical Society. You may see that our digs are a little bit different these days, but we just love exploring history when it comes to all that too. This is the El Paso Physician. I'm Kathrin Berg. Good night.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.